Well, good afternoon, and thanks for joining us. This is an area that I have been particularly interested in. I'm a pediatric urologist. I'm relatively new to Washington. Was down at University of Virginia for about 5 years before that and in Boston, and I've had the opportunity of being involved in formulating the American Urological Association's guidelines to managing vesicoureteral reflux, which of course is linked to urinary tract infections, and then was involved in discussing and responding to the recent AAP guidelines that I assume most of you are familiar with to some degree. And this is the article published last fall. Ken Robert was the lead author in this, and we had the opportunity of actually debating this at the AAP last fall in Boston. And to say it's a contentious issue is to sort of be mild, and the reaction both in the urological, nephrological, and pediatric communities, I think, has been stimulating. I'm not sure we know exactly where we need to go with this, but what I'd like to try to do is to present at least my perspective on the guidelines, and to provide, at least for the time being, since I think this is an issue in evolution, a bit of a perspective on how at least I look at urinary tract infections as a urologist, and how I'd like to try to formulate some sort of a working partnership with all of you in pediatrics in terms of taking care of these kids. Clearly, we don't want to overtreat them, but we don't want to let things slip through, and this is part of the challenge, I think, that this embodies. I'm not sure that I will be able to guarantee that I will make sense of this to you, but I'll give it a try. And really want to cover three things, and really what do they say, and to make sure that everyone's on the same page, to review the guidelines and some of the areas where there is confusion, concern, and controversy, and touch on why we think there's those issues, and then what can we do in the meantime until some clarity comes about, and I'll talk to you about what may be on the horizon with some clarity. So keep in mind, even though we as the pediatric urology community don't fully agree with the guidelines, there are many elements of them that are very important and we are in complete agreement with. And I'm not going to try to go through them in any great detail, except the area of sort of evaluation. But the points that are, I think, critical, that we have to some degree been emphasizing in our teaching for many years, is that a febrile child needs a urinalysis and a culture before treatment. To treat empirically on the basis of simply a dipstick or a foul-smelling urine is not going to be productive, unfortunately, and may lead to a lot of confusion and over-evaluation. I think that's part of how we got where we are. And that should be with a catheter or a suprapubic aspirate. I don't know many people who do suprapubic. How many people would do an SPA in your office? Well, a few, but not many. It actually is probably less traumatic to the child, but if you're not comfortable with it, then you shouldn't be doing it. I've never seen a complication from it. If the child is low risk, then just do follow-up. If the child is high risk, and the guidelines do go into some detail as to risk levels, we don't really have time to get into that in detail, then you should certainly culture it. I think that one of the big changes is that a change in the diagnostic criteria for UTI requires both a positive UTA and, not or, and, a culture of greater than 50,000 colonies on a cath or an SPA. And that's different than the greater than 10 to the fifth. And I think with a well-collected specimen, greater than 50,000 is fine. Then treatment should be based on practical considerations, be it oral or parenteral, and this, of course, depends upon the clinical situation and the child. And keep in mind, and I should have emphasized this at the beginning, these guidelines are for children under 2 years of age. So the post-toilet trained child is really not impacted by this, although one of our concerns is that people will lump them all together, and that may not be appropriate. Action Statement 5 said that febrile infants with a documented UTI should undergo a renal and bladder ultrasound, and this was hotly debated in their group. We feel this is at certainly the minimum. And it should be done by someone experienced and qualified to do a pediatric ultrasound, and that is not everybody, and this is one of our concerns. Because Action Statement 6 then says that a VCUG should not be performed routinely after the first febrile UTI, and it's only indicated if the renal and bladder ultrasound shows hydronephrosis, scarring, or other findings suggestive of high-grade reflux or obstruction. So they don't care about low-grade reflux, and that's one of the concerns. This also assumes uniformly performed ultrasounds, and that is not always the case, as I'm sure you're all aware. And further evaluation should be conducted if there is a recurrence of febrile UTI. I think most of us could agree on that for sure. The basis for this conclusion is really shown here, that several studies, and we'll talk about those a little bit, have suggested that prophylaxis does not confer the desired benefit of preventing recurrent febrile UTI. Therefore, if prophylaxis is in fact not beneficial, and VUR is not required for the development of pyelonephritis, some kids can get pyelonephritis without reflux, we'll talk about that as well, then the rationale for performing VCUG routinely after an initial febrile UTI must be questioned. That's a good question, but it's really based on the critical element of if prophylaxis is not beneficial for febrile UTI in the setting of reflux, then surely there's a concern. Action Statement 7, the final one, is that after confirmation of UTI, parents should be instructed to seek prompt medical evaluation within 48 hours for future febrile illnesses. And they do state, and this is an important comment that is recognized, that early treatment limits renal damage better than late treatment. So responding quickly, therefore knowing that there's a risk and there's a concern, is going to be important, and that's also one of our concerns. So the question is, if prophylaxis, CAP, is not effective in preventing UTI with reflux, there is no rationale to diagnose it. And that's been the contention that's been emerging really since Eduardo Guerin's paper in 2006. And this has really challenged, in many ways, our view of reflux in a lot of different ways. Now, I don't have to tell this audience the significance of UTI. I'm sure you see it every day, and you see the range from the little girl who has some dysuria to the infant who's in the hospital and septic. And this is one of our concerns. There's a huge range, and particularly in the younger group, you can't always tell on Thursday afternoon with the child with a little bit of fever and crankiness what she's going to look like 24 hours later. And are you going to be in the hospital with her, or is she going to be calling you from home, or her mom, to say she's doing better? And this is part of our concern. All of you can read this. It is a high incidence. 8% of girls eventually will have a UTI of some sort, not necessarily febrile. 40% will require hospitalization, 40% may have transient renal damage, and maybe half of those will go on to have permanent renal scarring. A fraction of those will have progressive problems. So it clearly narrows down to a small group, but they have a significant long-term health impact. And that is very difficult for us to estimate, and particularly hard to say in a child sitting in front of you who just had a febrile UTI, is this going to be a girl who gets hypertension during pregnancy and actually has some problems due to renal insufficiency? Hard to say. It's always useful to look back in history, and this is drawn from a paper in the early 60s and reflects clearly historical clinical experience. But in 11 to 27-year follow-up of kids hospitalized for UTI, and this was from Mass General, 8% had progressed to renal failure, and 22% persisted with untreated or recurrent UTIs, and 18% died. I mean, this, fortunately, is not what we see today, rarely at least. And of those males, it was typically within a month of the diagnosis. So this clearly can be a very significant illness. One of our concerns is that we may be shifting back to history if we don't learn some of the lessons we've learned. And one of the lessons we learned is from Jean Smellie in England, who was really the godmother of prophylactic antibiotics for UTIs. And this is one of her many papers looking at children who were, but mostly had vesicoureteral reflux. And the blue bar is the frequency of UTIs per patient year prior to taking antibiotic prophylaxis. and the red is after prophylaxis. And these kids were assessed with biochemical tests of the presence of trimethoprim sulfa in the urine. So their compliance was very good. They also had bowel and bladder management and stuff. But this is what triggered the period of time where we used prophylaxis to prevent infection while we were waiting for reflux to resolve. The challenge was, as that became standard of care, people tried to validate it with studies, and it's never really been done very well. There were several studies in the 70s which are used in the Cochrane analysis. None of them could really prove it very well, and there were just too many confounders. Patients with a wide range of ages and a variety of diagnostic criteria. Most of them were not blinded. None were intention to treat analysis. So the Cochrane analysis, which many people hold up as the gold standard, basically said we can't say. Now it doesn't prove it doesn't work, but we haven't been able to prove that it does work. And really the small number of poor quality studies gives no reliable evidence of the effectiveness of antibiotics in preventing recurrent UTI. Nonetheless, this is what we did, as most of you know. When a child was diagnosed with reflux, they got prophylaxis. And in my experience, it typically worked pretty well. For a child who had had recurrent UTIs, they didn't have as many recurrent UTIs. So where has this evidence for lack of efficacy evolved from? And these are some very important studies that I hope some of you are familiar with. I've unfortunately spent many hours trying to understand them, and I'm not sure I do. So why don't we get into why there's confusion, concern, and controversy. And really, why should we be concerned about the recommendation not to perform a VCUG after the first febrile UTI? And I see three basic points. That it provides an inadequate safety net for kids. That the guidelines, although well-reasoned, I think well-intentioned, just don't reflect the real world. And I think most of us work in the real world. I'm not sure I do anymore, but it's downtown. And the data and interpretation are flawed, and this gets into more statistics and things, but I think the safety net question is an important one, and to many ways this is where you as the primary care physicians really need to weigh in on the impact of this. We know that the risks of scarring and stuff is low if we miss reflux, because this is in essence what's going to happen. We're going to have a number of kids who don't get VCUGs and then may have another infection. What's the risk of that? And it's difficult to say. We know that pyelonephritis and scarring can occur without reflux, but reflux increases the risk by a factor of at least 2.6 to 3. And this was shown in our AUA guidelines in a large meta-analysis, as well as by a paper by Hans Pohl in our department at Children's. We know that the grade of reflux correlates with scarring risk. So higher grades, more scarring risk. The number of infections correlates with scarring risk. Delays in therapy can be associated with more renal injury, and this, of course, becomes important if we're in a watchful waiting type of a mode. And occasionally, the scarring can be quite severe, and I'll show you a paper by Malcolm Coulthard from England that was rather sobering to me. So acute pyelonephritis and renal injury is increased with reflux. Now, if you get an infection and you get pyelonephritis, okay, that can happen without reflux. But if you have reflux, the risk of permanent renal injury is 2.6 times higher. So it's a significant risk factor to have reflux if you're going to happen to get pyelonephritis. Reflux per se isn't the cause of pyelonephritis, but it adds to the risk of renal damage. So certainly not insignificant. This has also been shown by a recent paper by Sheikh et al., and this was under Alejandro Hoberman in Pittsburgh, who did some very nice meta-analysis on this as well. These are data from Sweden that's done a great deal of research in reflux and UTIs, and it clearly shows that the number of UTIs correlates with the percent having DMSA or kidney scan abnormalities. So these are renal scars. And reflux grade correlates with the risk of DMSA abnormalities as well. So not only the number of UTIs, but the grade of reflux increases your risk of scarring. Delay in therapy can be significant as well. And this was a paper from Greece. And many people interpret this to say that the delay, and their conclusion was that the delay doesn't increase the risk. But they were playing a little statistical game there. Because if you look at the actual percentages of kids treated within 24 hours, had 40% had acute damage, half of those persisted, so 20% had permanent damage after one episode of febrile UTI, in contrast to those treated late, 96 hours, where although the percentage who had acute damage having permanent damage was still 50%, the total number was almost twice as much. So clearly, making the diagnosis early is going to allow you to limit the total impact of that episode, and that's one of the concerns about a watchful waiting course, especially when we've even said to the parents, well, this first UTI doesn't make much difference, don't worry about it, come back if you have another one. We'll get into that. And then this was an older study by Jean Smelly, again in England, looking at the fact that new scars in refluxing children usually occurred with delayed treatment, absence of antibiotic prophylaxis, and social problems. And social problems is not an insignificant issue, certainly in my practice. And this is a paper by Malcolm Coulthard, a nephrologist in England, who looked at a group of kids. This is not a population study, but a selected group. All had reflux, and they had UTIs, and they had normal DMSA scans before the febrile UTIs, and then he looked at how many of these, or what degree of new damage could occur. And it's quite significant, to the point where some kids with one bad UTI were losing most of the function in that kidney. These are the kids with this type of scarring. No, they may not go into renal failure, but their risk of hypertension and issues with pregnancy are going to be significantly increased. And interestingly, this did not seem to disappear as kids got older. It actually was worse. We usually say that the older child who can say it hurts to pee is going to be picked up earlier. That was clearly not their experience. This is not a general experience, but it certainly is something to pay attention to. Another of our concerns is that these guidelines may not reflect real-world practice. And we work in the real world, although we'd like it to be like Disney, it just isn't. And I'm always a little hesitant about this slide, but... So one of the questions is, how well do we follow guidelines? And there have been two papers on this, and this is one of them. Following the previous AAP guidelines on UTI, 70% adherence to the recommendation of method of urine collection. So that's 30% were not paying attention. Now, there may be reasons for it. And 61% adhered to the recommended imaging workup. Now, it'll be interesting to see how many people follow the current guidelines, but it does raise a question that they may not be strictly followed. This is, again, the real world, a busy practice, and perhaps poor relationships with the family, and that they don't bring the information and stuff like this. And this is one of my concerns, and this may be your experience. It certainly has been mine. Do patients and families always remember how many infections they've had? Was this their first? How do we know it's their first? Perhaps it was an otitis media that we thought it, or that we thought it was an otitis media and was actually a UTI 6 months ago. Do we have the necessary documentation of a UTI? Very frequently, I will get a referral for UTI, and all it says is, UTI, please evaluate. We need the information to make the decision. We all should use that information of the urinalysis, the culture, the sensitivities, and the clinical presentation to make a decision, what kind of a UTI was it? Again, there's a spectrum. We need to understand that child's risk. Do families always see the same pediatrician or caregiver? This city, certainly, this region is extremely transient, and I'm seeing kids who are living in different countries and coming through here and coming on and off insurance, and I think that that is a significant risk for these families, and there is some evidence that that impacts quality of care. These are just some examples of the issue of being uninsured and insurance gaps on overall care of a variety of pediatric conditions, and I'm not telling you anything new. This is something you know very well. But this is a real concern that I see impacting on febrile UTIs, is these kids may move from insurance to no insurance and then not be able to get the evaluation on their second UTI when we could have perhaps identified their risk on the first one. So I have concerns about the evidence. This could be too long a lecture if we went into the nitty-gritty of how they did their statistics and some of those issues. But fundamentally, they took a variety of studies that were all done differently, many of them in different countries, many of them structurally good studies, but very narrow. And others had very different criteria for both patient inclusion and, as we stay here, variable culture methods. There was a wide age range in the Curr study. It was from 3 months to 18 years. So it's very difficult to make a conclusion on such a wide age range. Most of the patients were relatively low-grade reflux, so their risk of renal damage and recurrent febrile UTIs was less. There was a very low incidence of initial renal abnormalities, so probably a relatively low-risk population in many of these studies. There was no assessment of medication compliance, and we know that's a major issue, and no assessment at all avoiding dysfunction except for one of the studies from Sweden. And Eduardo Montini, who wrote an absolutely excellent review article last fall in the New England Journal, and I would recommend it to you. He's from Italy, has done one of the studies, but basically in looking at the various other studies in his review said they were really insufficiently powered for any analysis according to grade of reflux. So we are lumping all reflux together, and that's one of our big worries. But that's how you have to do meta-analysis. And they combine studies that are done differently and may not be set up or designed to detect the differences that they're asking for. Beyond that, there are specific problems with combining studies, and one of these is this fascinating thing called the amalgamation paradox or Simpson's paradox, and this is a result of combining studies of different sizes, and it's often, so what you'll get is a contrary result. Even though both studies may show one effect, combining them shows a different effect, and it just doesn't make sense, and that's why it's called a paradox, but it's often due to what is called a lurking variable that's not accounted for, where there are different degrees of that variable, and what we think this is the issue of bladder and bowel dysfunction. And this is voiding dysfunction, dysfunctional elimination syndrome, or whatever you want to call it, which I want to emphasize a little bit. But I think we have to be very cautious about taking conclusions from data that were not all that good to begin with and have significant limitations, and then combining them and saying, well, because we combine them, then it's stronger. Now, meta-analysis has value. We used it in our guidelines, but we're also very cautious with it because we also are familiar with the problems. For instance, this is the Curr study that you probably are familiar with. And the difficulties was it was powered to detect a 20% difference with 60 patients in each arm. That's a small study. But they had a very high dropout rate and more dropout in the prophylaxis group. It wasn't designed as intention to treat, so you have some problems with that. It was very short term, 12 months in this realm of things is short, and it had this wide range of ages. The study from France had a number of problems. It too concluded there was no benefit to prophylaxis except in boys with grade 3 reflux. But they also observed a high rate of UTI related to an organism sensitive to cotrimoxazole, the prophylactic agent, in children treated with such antibiotics. What does that mean? Probably the patients weren't taking it. So no compliance. And it's a problem, but that's not the question. We need to get compliance by education, but we can't condemn a modality if people aren't actually using it. Their voiding pattern was not explored. Most of the boys were uncircumcised, so had a higher risk, and they used bag specimens for collections, which the guidelines, even though they use these data, then have a recommendation completely contrary to that. So a bit of a concern. The Swedish reflux trial, a large study from Sweden, and this is the group on just surveillance in terms of freedom from UTI. Prophylaxis definitely prevented UTIs in this population, and this was a very significant difference. And it also showed more scarring in those kids who had breakthrough UTIs, so a concern. And this is part of the difficulties. We have studies that show there's a benefit, other studies that show there isn't. What's going on? Part of the problem, I think, is that reflux overall has been sort of decriminalized, and it's being seen as a homogeneously benign condition. And that just isn't the case. We know there's a subset, and in a way, this is really the same narrow view as that from 3 decades ago in which all reflux was seen as dangerous and got surgery. That clearly wasn't appropriate either. So to me, UTI is a warning sign for risk, and ignoring it once may send the wrong message to the family and the practitioner. And that's our concern, that then the next UTI is not going to be moved on as quickly as it should, and may not even be detected. And I think even just having the diagnosis of reflux improves the ability to the family and the pediatrician to respond appropriately. Doesn't necessarily mean you have to put them on prophylaxis, but you know they're at risk, and then you can make the decision a little more intelligently. So, how do we reconcile these highly variable study results? Does this apply to all reflux patients or only some? And can we figure out which ones it applies to? And how are we going to sort of deal with this on a day-to-day basis? This was our guidelines that we published in 2010. It's pretty tedious reading, but we did summarize it in 2 journal articles that are available on the internet. Probably the most important factor of this was that we could very clearly demonstrate with a variety of data that bladder and bowel dysfunction is a major predictor of whether you're going to get a UTI and whether your reflux is going to behave badly. So in kids who had bladder and bowel dysfunction, the incidence of UTI on prophylaxis was 40%. For those not on prophylaxis, it was 12%. So you can see how if you have more or less kids with bladder and bowel dysfunction in your study, the outcome of the study may be determined not by your treatment, but by the bladder and bowel dysfunction. And if bladder and bowel dysfunction, and there's a lot of evidence to support this, is the underlying major cause of UTI and of persisting reflux, then that's what we need to focus on. And we don't have time to spend on this. I could give this for an hour and talk about it. Most of you are familiar with it. And it can be the holder who's just too busy to go, or it hurts to go, the kid with the unstable bladder or urge syndrome, and they resist that urge by tightening up their pelvic floor, and then they don't empty very well. Or the child who has a bladder, I hate the term lazy bladder, but basically they've allowed it to stretch out, they don't empty. These are the kids who get UTIs, and many of them have reflux. So, what can we do? So there's a lot of uncertainty. These are new guidelines. They recommend a very significant change in practice that I think can have a significant impact on patients, and I think we have to be cautious about this. But today, or tomorrow when you go back to your offices and clinics, you're going to have patients with UTIs, pyelo, and possible reflux. They're here for us to take care of today. And we're treating individual children and not statistics, and I found that children tend to ignore statistics. So, does antibiotic prophylaxis prevent UTI and renal injury? Yes, in some children it does. I think there is good evidence for this, but it may not be needed in all children with reflux. It benefits those with higher risk of UTI, with prior UTI, with scarring, and with bladder and bowel dysfunction. So if some children can benefit in terms of preventing recurrent febrile UTI and renal injury, then I think that reflux should be sought in those at most risk. And so who are those? So when we look at a kid with UTI, then the questions that should be going through all of our minds is this a real UTI? Or is this a kid who's having some accidents because she's a dysfunctional voider, and you have a culture that was obtained at an outside ER when the child had a viral infection and the UA was negative, but the culture was positive? Don't know. What was the clinical picture? Was the child toxic or pretty much asymptomatic? What was the fever? Was it a real fever or just a 99.2 or something? How does the child void? Is this child constipated? Is there evidence of bladder and bowel dysfunction? Is the normal ultrasound, so-called, is that reliable? Do you trust the reader? And I don't expect you to learn how to read these things yourselves, but there is high variability, and we need to be sure about that. Are you comfortable that the parents are going to come back with another episode? Or are they transient? Are they possibly running out of insurance? Or can you even guess? And are you and the parents comfortable to monitor without further imaging? And if this is all in a nice, ideal situation, fine. I think that's very reasonable, as long as everybody's aware and informed. But if you have concerns, then I think the better place may be to do the evaluation and then follow up with treatment. And this is the sort of thing that I got recently. A 2-year-old uncircumcised boy had dysuria, fever to 102. He was fussy, but taking PO well. And although it's a little hard to see, his leukocyte esterase was negative, his nitrites were negative, but he had greater than 100,000 of 2 organisms, and they didn't even speciate. So this was, please evaluate for UTI. It probably wasn't a UTI. No, this was a... Don't know. I don't think I learned that, and that's one of the other questions. But he was uncircumcised, so even if it was a clean void, I'm not sure I can trust it. So we chose not to. Actually, I think this kid got evaluated without our making a choice. But this is the kind of thing we want to think about. So here's another example. Here's a 2-year-old girl with fever, irritability, grabbing her perineum with voiding, poor oral intake. She's vomited twice. Her urine shows 3+ lukes, 2+ nitrites, white cells, and the culture grows greater than 50,000 E. coli, and it's a catheterized urine. Would you consider using antibiotics to treat her? Treatment. Okay. Would you do an ultrasound? Good. Would you do a VCUG? How many would do a VCUG? Right. Now, do you have a good relationship with this family? Do you trust them to come back? Do they have insurance? Or are you seeing them for someone else? Those are the questions. And this is the child where it's difficult. And if you have a good relationship and you're willing to follow them closely, I have no problem with not doing the VCUG. But you got to be sure that you know they're going to come back. How about this? A 4.5-year-old girl with fever, complaining of painful urination, history of constipation and wetting. Her urine shows 3+ lukes, 3+ nitrites, white cells, and grows greater than 100,000 E. coli. It's a voided specimen. Antibiotics, would you treat her? Yes. Would you do an ultrasound? Would you do a VCUG? Okay, good, because this child is not covered by the guidelines. She's 4.5. This child, I probably would not immediately do a VCUG, but I would strongly consider it because she's a dysfunctional voider. And she's got all the story of it, and she's getting a febrile UTI. And those are the kids that you need to have some concern about. And the guideline actually does not address them. And that's one of my worries, is that we quickly generalize, well, 2 is nearly 3, so I don't know. So in summary, and I think I've dribbled on a little too long here, UTI evaluation needs to be tailored to the child and their risk of recurrence and renal injury. And I think that's trying to understand a risk-based evaluation is what we're pushing. This should be a collaborative decision-making with parents, pediatricians, and specialists if you want to talk to us. And I am totally open to doing this, and I give out my email if people want to just contact, what would you do in this case? And there are many of these that are ambiguous. There is evidence that prophylaxis can be effective in the child at higher risk for UTI, and those are the kids we want to identify. And we should not forget what has been learned about reflux in the last 30, 35 years and its risks. Because I think, although the data are hard to prove, that we are seeing fewer kids with severe scarring and some of the long-term complications. And this is George Santayana's famous quote of those who do not remember the past are condemned to repeat it. And I certainly hope we don't. But I hope this gives you a bit of a perspective on the guidelines. They are not simple. There may be some new data coming out with the RIVER trial, which is being run by NIH, but it's going to be 1.5 to 2 years before we learn that. And I don't know that it will be definitive, but they're trying. So hope this was helpful, and if there are questions, if we have time, I'd be happy to take them, or outside. Right.
Can you repeat the question?
Private practices, thank you. At several private practices that employ this use of sending out bagged specimens, and then you get back 2, 3 organisms or 1 organism, and it's kind of hard to make sense of what that really means. Right. So just your position would be great.
Yeah. So the question is about the validity and utility of bagged specimens. Fundamentally, I would never make a definitive diagnosis of a UTI with a bagged specimen, and that's what the guidelines say very clearly, and I totally agree. A bagged specimen in a low-risk child, maybe a little fussy, maybe a low-grade temperature, is fine to rule it out, because if a bag is negative, the child doesn't have a UTI. It's going to take you 24, 48 hours to get that result, and by that time, if it's a viral fever, it's probably gone and the answer's in, and you've sort of done due diligence. But the worst thing would be to be suspicious, get a bag, and then start antibiotics. Because then, if the bag comes out with 2 or 3 organisms in an ambiguous result, you don't know what to do because you've already started treatment and you won't have an answer. And then we won't have the ability to make the thoughtful decision, was this a UTI or not, and therefore, what kind of evaluation is appropriate.
One more question, then we'll break.
Yeah, Dr. Peters, on your earlier slide, unless I misread it or it's a typo, it said that 2.7% of boys and 0.7% of girls had significant bacteriuria by age 2. Unless it's very different from my experience, I think it's the other way around.
I think these are sort of long-term populations. At some point, it's not a point prevalence. It's over time that they will get that.
Boys more common than girls.
Oh, in infants, it's way, way back. I think that what this may reflect, I'm trying to, yeah, this is small kids and, by age 1. But again, part of this may be a misdiagnosis, especially if they're not circumcised, because we know that the incidence of UTI in boys is higher under age 1 than it is in girls. But again, some of these, if I'd have to look back where these data came from in terms of the studies, how well they obtained a culture, and whether this was an appropriate culture or potentially contaminated.